Hello, welcome to this episode of the 260. In this episode, we have Grant Neuhaus, who is a charge ER nurse as well as a paramedic. Grant has been a paramedic for 10 years and a nurse for 5, and his experience in the pre-hospital setting combined with the ER lend us to some wonderful learning points that I'm really looking forward to you all hearing. In this episode, we talk about bridging the gap between the pre-hospital setting and the ER and what we can do as pre-hospital providers to match up with the efforts of the ED to just really optimize the continuum of care and optimize patient outcomes together. So I'm looking forward to this episode and hopefully you all enjoy it. Let's get into it.
60, 75 hours, 10 seconds.
Here in the pre-hospital, we're
Mhm.
like, okay, until they're warm, but that's kind of
Right.
subjective. Is there like a objective benchmark you guys hit? Like we want a temperature of at least this before we're
So there is, it's somewhat physician dependent, but it is basically, I mean, you're looking for a core temp closer to baseline. So somewhere like over that, like in between that 95, 98 range, like we will use, we can use like a indwelling Foley with a temperature monitor to give us a more core temp and know where we're at. And then we're using as many warming methods as we can to get them to that temperature before we make that final determination. Now, some of that depends on, what was the cause of the arrest. So was it something where we think cold was a factor versus was this a pretty obvious like cardiac etiology, respiratory etiology? We know what caused it. So we know their temperature is not really the factor in this. It's more, this was, we know what caused it. Yeah. We know what it was more or less. And we're just somebody that was presenting with, a STEMI and then went into cardiac arrest or something like that. Then we don't necessarily monitor that temperature as like a, knowing that, they're at this temperature, we're going to call it but if it's cold was a factor or anything, then there is a benchmark that we're aiming for before we make that call.
Never really thought about that, but I guess that makes a lot of sense.
Yeah.
I mean, when you have those diagnostic tools privy to you, like use them.
Yeah, exactly. Yeah. I think that's one of the big divides between EMS and the hospital is like some of the calls that you make out in the field, you're making them off of what you can see, and we just have a lot more data. We can do bedside labs and have electrolyte levels in 5 minutes or less, and you guys don't have that. Like you don't know that, so we can be working a cardiac arrest, run an electrolyte panel, and be like, their potassium's high. We can do X, Y, Z, and target that. And once we've targeted that, then maybe we can get get them back because we can take care of whatever arrhythmia is being caused by that potassium problem or whatever it is.
I'm ignorant. Is that ISTAT?
ISTAT, yeah.
Okay, I thought so, but I wasn't quite sure. My last job was MIH, and that was like a carrot they were dangling in front of us. They were like, we're going to get ISTAT. And I got all excited. But
I think it would be really valuable in the field. I don't know that it's really tough to make it realistic just because it's an expensive piece of equipment, and they have to be calibrated, and bouncing them around in the back of a truck I'm not sure how much it would mess with the calibration and everything on them, but I know there's EMS services using them, so I'm sure they've figured that out. They have a way to do it, but it would be very helpful, especially in rural EMS where they just have the longer transport times. I know like here in Fort Wayne, we kind of lose a lot of those cool opportunities because we do have just such a quick transport to the hospital that they think we don't need all these things you don't need to diagnose in the field, just get them to the hospital, let the hospital figure it out, which is true sometimes but there's times when you have transportation delays for whatever reason that having that data could be valuable. So
anyway, we've been talking. Tell us a little bit about yourself. We know you. We're familiar with you, but it's been a while since we've talked with you, and most of our listeners don't know who Grant Neuhaus is. So where are you from? How'd you get into EMS? How'd you get into nursing? Like, what's the quick and dirty here?
Okay. So I grew up in Huntertown, small town just north of Fort Wayne. Growing up, my dad suffered a spinal cord injury when he was 15 and had he walked on crutches for a while, but eventually was wheelchair bound. And so my whole life, I knew him as in a wheelchair and eventually having complications that come with years of suffering a spinal cord injury. And so I saw him in and out of hospitals or, even being transported by EMS. And so I kind of, from a young age, knew that I kind of wanted to be part of that team that took care of people like him, whether it was going to be somewhere on the physical therapy side, rehabbing people that were like, in his condition, or the acute side of taking care of him in the emergency type situations. I couldn't decide what that was going to be. Got to high school, and my senior year, my mom worked for foreign community schools and was like, hey, I don't know if you've heard about this, but Anthus Career Center has this EMT program, and you could take it, and by the time you graduate, you're an EMT basic. And I was like, yeah, I mean, that sounds sounds like a great idea, a good springboard into whatever medical career I decide to go into. And
That's come up a few times now with
Yeah.
guests. Like
yeah, it's a
that being the
huge
springboard.
thing. Yeah, the EMT is an EMT basic is just it's a great way to get into it, and it's not a long time to go to school. Like, I mean, for me, it took longer because it was just built off the school year. But for the typical person,
Yeah.
it's not a long program, and gets you introduced to it to the point where I feel like you can kind of get an idea of like, am I going to be into this or not? Is this something that will, is the medical field for me, or is it not, kind of? Or even just being a first responder or being in public safety, is it kind of something you'd be interested in? So turned out I was, and it worked out.
Spoiler alert.
Yeah, so I batted back and forth for college, whether I was going to go to nursing school or I was going to go to paramedic school, and I ended up applying to the paramedic program at Ivy Tech and got in. And
Did you
that
go
was
straight
the start
through?
of it all. Yeah,
Did you go
I
straight
went
through, or were you
went straight
basic?
through. I
a
worked as a
little bit?
basic. Only job I had as a basic was at BF Goodrich as a EMT responding in the plant, which got me some experience, a little bit of hands-on with some people suffering from medical emergencies. Not a lot. It wasn't 911 by any means, or the kind of volume you see working in like an EMS system in the city or anything, but enough to keep me interested and keep me going to paramedic school. And I got through that, and while I was in paramedic school, got my advanced EMT as part of the program. They put us through testing for it and allowed us to get that while we were in school. So before I finished,
That was a thing.
yeah,
Yeah,
before
I
I
did
finished,
too.
I got a job at TRA as an advanced, and yeah, I did that for 5 years, and decided my wife is a nurse, and saw her and the job she was doing, and thought I was, kind of seemed interesting, and took the opportunity to apply for a nursing program and got into that. And now I've been doing that for 5 years. So it was a kind of a wild ride to where I got to, but every bit of it was worth the experience. That's for sure.
What kind of nurse is your wife? Is she like OB?
She's
ER?
emergency as well.
She's emergency. Oh, do you guys work together?
We do not work together. She works at Parkview Randalia,
Okay.
and I work at Parkview Regional. So we kind of split the hospitals there.
Yeah.
So.
Could you work together?
I think we could manage, but we've always kept it that it's easier to work at two hospitals because you don't take PTO from the same place at the same time, and we'll keep maintaining that's the reason we don't work at the same hospital.
Yeah, me and my husband, we would pick up on an ambulance together every now and then, and it was fun. It was fun until he thought a patient was going to hit me, and he pushed me out of the way, and then I got mad at him, and I was like, if I'm gonna get hit, it is my own damn fault.
Yeah, I think it would be especially tough. Like, and Randalia's ER can be a little bit more rowdy,
Spicy.
as both of you know, the history of transporting people there, and I think I would have a hard time watching her have to be in those scenarios if we were working the same shifts, which likely wouldn't be, but there would always be a chance that we would be. And I don't know if I would love that because she tells the stories when she gets home, and I'm not always like thrilled.
I don't know her that well, but what I do know, she could hold her own.
Oh, that's absolutely true.
Yeah, she could hold her own.
Yeah, absolutely.
It might be the other way around. She might be looking out for you.
That's very possible. Very possible.
Are you still a paramedic?
I am. Yes.
Okay, awesome.
So I still pick up my couple shifts a month over at East Central.
Do you?
It's every once in a while, it's not 2 shifts a month, and luckily they put up with me and they have patience with me when I can't make it over there. But I've enjoyed my time there. It's a nice place to work, and it's very laid back as far as just the environment is nice. To be at a station and have the ability to spend time with a group of people. It's more like the hospital where at the hospital you have a whole group of people that you're with all night and you're working with. In a standard EMS system, it's like you and your partner, and it's just you're out on the road basically. And so being back in that fire station setting is kind of more similar to what I'm used to at the hospital. It's kind of nice to have that group camaraderie. So
do you have your fire as well, or?
I never went down that road. I batted it around many a time, but it was never for me. My grandpa was a Fort Wayne firefighter. I know I would talk to him about it when I was young, and he always joked and said, "No, don't do it. Don't become a firefighter." But it was a lot different back when he did it. They didn't have SCBAs or any of those things, and it was a little bit rougher job back then, and it's definitely a more of a career now, and more you're safer in a lot of ways and everything.
Safety's more of
I
a
think that was
priority than
more where he was at, is that it was just not a very safe job, and he just didn't think it was for me, and so I think I kind of in the back of my head always thought like, I'm going to listen to him. I'm going to stay on the medical side and do that. And I think it served me well. So
There's nothing wrong with that. I mean, you got a lot of hats as it is. So
Yeah.
you kind of got to pick your pick your battles there. And
Exactly.
I think you're probably busy enough with
Yeah.
renovating a house and being a nurse and being a paramedic and being a dad.
Yeah, absolutely. Yeah, I've got plenty of time for all that maybe when the kids get older and I'm bored, I guess, but not
And you're
yet.
and you're not just a nurse. You were saying earlier you're a lead nurse.
I guess it's been about 2 years now since I became a nurse lead, which means I operate either as a charge nurse or what we call a PFC, which is a patient flow coordinator, basically just working with the doctors to make sure that labs are being drawn and things are being done to keep the department moving. And so it's more similar to like a shift supervisor position for, an EMS where you're not just in charge of one patient, you're in charge of all the crews and what they're doing. And if there's critical calls, you're try to be involved in those and make sure that you're supporting your crews when they're working with stuff like that. In the lead role, we're in any of the activates that come into the hospital to make sure that we are there to chart and support the care. Like if it comes down to, the nurses in the room need help with whatever procedure they're doing or whatever, then we're there for that as well. But really, we're there to make sure that all the right resources show up and do what they need to do. So.
It brings me, I was going to ask what like a typical day for you is like, but it sounds like it's very varied. I mean, yeah.
Yeah, it's definitely more varied than when I was just at the bedside. Just to kind of cover both, because I feel like that's a good perspective. Is the bedside nurse in the ER is usually carrying 3 to 5 patients at a time. They have more critical patients. We try to bring them down to, if we can bring them down to 2, that's best case scenario. Or they can use, they use their team as support for their other patients while they're caring for the more critical ones. They are transitioning through having 3 to 5 patients, and it's not the same patients all day. They're sending patients upstairs or discharging and then gaining new patients constantly throughout the day. And in some areas of the ER, they pretty much have 5 patients all day. But again, not the same ones. So it's, doing the initial assessment on one, getting through all the treatment and figuring out what, the disposition of, are they going upstairs, are they going home, dealing with that and sending them to wherever they're going. And then they're gaining another one back into their rotation of 5 and then starting that whole process over. So it's just a continuous loop. So it's a lot to manage. There's a lot of priority management and being able to know which patients are the most critical and kind of doing a self-triage within your patients to know which ones need things done first. That bedside nursing is definitely a complicated role and varies from the paramedic life of, having maybe 1 to 2 patients on average. You may have a scene where you're in charge of multiple patients and having to call in resources for those patients. But typically in transport, you've got 1 to 2 patients that you're responsible for. So I think prioritizing is a little bit different in that aspect versus what the nurses deal with on a day-to-day.
So you're not just sitting there sucking your thumb waiting for paramedics to bring you patients.
Definitely not that. Very, very rare that that's the case. I will say the charge nurse role does lend to more sitting than I definitely like. You'll find if you ask anybody for a review of me in the ER that I'm the charge nurse that's in the chair the least. I'm usually up and trying to do something. Sometimes that bites me because the things that I'm supposed to be watching are all from the chair. So the schedule and the things like that, the clerical work of the job sometimes takes a little bit of a backseat because I'm still not ready to take off the running shoes yet when it comes to helping out in the ER. So it's tough, but
it probably garners you some respect though too, because you getting your hands dirty. You're in the pit.
Yeah, I like to think that trying to find that healthy balance of being in the rooms and helping along with the aspect of, being at the desk and doing the clerical side of the job, that finding that healthy balance and making sure that people feel like they're supported. It's important to me to know that people see me in the rooms with them, side by side, bedside with the patients and doing things. So
You don't lose touch to what
exactly.
the average nurse does too, and it helps you manage them a lot better.
Yeah.
How have you noticed your paramedic experience transition into being a nurse?
As a paramedic, the assessment and like differential diagnosis is really hammered into you in school. You have to arrive on scene, look at that patient, decide sick or not sick, and start kind of working on if they are sick, why do you think they're sick? What's wrong with them? And how can I make that better? How can I at least support whatever condition that is until we get to the hospital? Or is it a reversible condition that I can fix right here and now? As a nurse, it's equally as important to have those skills. And I feel like, unfortunately, it's not as hammered in during nursing school. Nursing school is driven towards a wide array of nursing modalities. So you're talking floor nursing or, pre-op care nursing, cancer, whatever it may be, whatever type of nursing you're going to go into.
Yeah, very broad.
Very broad. They kind of have to take big swings at it to teach you all of this information. Luckily, there are programs as you get into emergency nursing that are targeted for emergency nursing and teaching you those assessment skills. There's specific ones for trauma, specific ones for pediatric. And so as you take those courses, and I've noticed those courses, they lean more into the way that we think as paramedics, which is nice to see that we have courses like that for nurses to get that mindset, because it gives you the ability to recognize and know when you need to go grab extra teammates, you need to go grab a doctor, you need to start doing things quickly because this patient is in, a critical condition or is not doing well. And you can say, this needs to happen fast, and you recognize it. And I think that I had that early on because I already had the paramedic experience. Mm-hmm. I was able to come into the ER and be able to recognize those patients and see those things. Whereas when you come straight in and just are a nurse to start with and don't have that background, it's difficult because you haven't had that emergency training quite yet. You've had nursing school, but you haven't had that emergency training. So it takes a little bit more time to get on your feet in the emergency room if you come straight from nursing school as a new grad. That background definitely helps.
I think you said that really well. It makes sense. What about the inverse? So your experience as a paramedic, I'm curious how your time as a nurse has impacted that.
I think it's changed my perspective on certain treatments that we used to maybe not do in the field or we would do in the field. There's different things. Some people would say, well, if I'm not going to use an IV in the field, then I'm probably not going to start one. And there were good arguments for that. It opens up, more chance for infection and things like that, because in the field, it's a little bit dirtier environment. You're going to clean, you're going to do those things, but it's just not the same. And so I heard that argument a lot when I was full-time in EMS, was like, well, I'm not going to use the IV. Why would I start one right now? The one thing I would say is that if you think that there's a medication that you might give, we have a pretty good knowledge as paramedics of pharmacology. We know a lot of medications that we just don't carry on the ambulance. So if there's something that you think, well, I can't give it right now, but they might give it at the hospital, having that IV established can be really important because it can speed up the timeline of the nurse having to come in. And, we're doing multiple things when the patient gets in. We're hooking them up for vitals, we're assessing, the doctor comes in and assesses. And sometimes when we're doing all those things, it's hard to get access into the patient and get an IV established. And so having that done ahead of time is important. That was one just like major takeaway. As far as overall takeaway, I think just preparing the patient in general for the emergency room. So we had actually talked before we got started here about, maybe, pop their shirt off, throw a gown on them. That's a simple thing that saves a lot of time when they get there. Honestly, can make EMS care easier. We're placing people on the monitor. We're starting IVs. We're putting nasal cannulas on them. We're doing things that if we already had their clothing off, those treatments can continue easier when we get to the ER. If we've got someone on nasal cannula and they started with their SATs at 90 and we've got their SATs up and they're supported now, and we get them to the ER and we haven't taken their clothes off yet, like we could have popped those off real quick before we put oxygen on them. And now when we get to the ER, we've got to take the oxygen off, get their clothes off. And by the time we put the oxygen back on, their SATs are already starting to drop. And all that progress we've made is now kind of going away again. So there's just little things like that I think could guide care. And it also just, I think, makes a difference in the perception between EMS and hospital staff of like, they're thinking of us and, they're thinking about what's going to happen next. And it would just, I think, maybe help that relationship a little bit. Because I do feel like sometimes there's a little bit of a riff, unfortunately, between the two.
Why is that?
I still haven't figured it out entirely. I'll be honest, when you asked me to be on this podcast, I thought, I'm going to ask around. I want to hear what people, like I said, so I was like, hey, what do you think? I mostly ask some of the leads I work with, like, what do you think EMS is doing? Or like, what do you think we could be, talking to them about that would help you with the confidence in them or any of that? And they really didn't have a great answer for me. There wasn't like this one thing that like, hey, if they did this would really solve all of our problems. This would make us all, feel better about it. I think it's just tough because we've always had that thing that happens in healthcare where the patient tells you one story and then they tell me another one 5 minutes later. And I think that unfortunately, that is one of the biggest things that has hurt the EMS hospital relationship, is that EMS calls in a report. They say, here's the story. Here's what we have. We get there and the patient says, I have chest pain. Well, they never said they had chest pain the whole time they were with EMS. That wasn't in the report. And turns out sometimes those patients that had chest pain that never said it in the field at all hit the hospital, say they have chest pain, you throw an EKG and, oh, they are having a heart attack. Like, well, okay, they never told the EMS, but then if EMS says, well, they never told me they had chest pain. Well, it's really hard to like, at that point, it's like, well, the hospital's mad because you didn't do an EKG. Well, they were complaining of X, Y, and Z. They weren't complaining of chest pain. So it's just that, that game of telephone you played as a kid, you say something in somebody's ear and they pass it around the table. And by the time it gets back to you, it's completely muttered and it's not the same thing. And it's kind of the same thing that happens in EMS. It's just tough.
In my limited experience, I think that we just need to give each other grace and remember that we're all here on the same team. I'm here to help you.
Yes.
And doing the best I can. And, I need to think about things from your perspective too.
Yes.
Because, okay, that's valid. Like, oh, this patient has chest pain and you didn't do 12 lead and you didn't provide aspirin or nitro. Like, that upsets me. Those things should have been done. They're paramount. Well, that's fair. Like, that's fair that upsets you. That makes sense.
Right.
But, let's just have a respectful conversation. And, people are also allowed to, be people. They're going to make mistakes. And
absolutely. And I think those are both exactly the right points. We are all goal driven to the same goal. We want the patient to be better. Like, we want to treat this patient. We want them to leave whatever care. So you want them to leave your care feeling better than they did when you got there. And when they get to us, we want them to leave our care feeling better than they did when they got to us. So that's really, you're getting them to us with as much as you can to get them to feel better. And then our job is just to take over from where you got them and to keep it going. And we're all working towards that same goal. I think it's forgotten sometimes, and it's unfortunate that it is that way, because I feel like being on both sides of it, I want EMS to have a good perspective of us at the hospital, and I want the hospital to have a good perspective of EMS, because I am both. And it's tricky to ride that line of like, all these medics, they said this and that. And, it's like, well, I'm sure that they had a lot going. Maybe they had a lot going on. Maybe it's chaotic sometimes when it's just you and you've got a critical patient. There's things happening, and you're trying to get all of this stuff done in this finite amount of time. In the hospital, when we have a critical patient come in, there could be 3 nurses in the room, and there's a doctor in the room. There's a respiratory therapist. There's a pharmacist. In the back of an ambulance, you and your partner are all of those people. And the paramedic being pretty much the respiratory therapist, the pharmacist, and the nurse, all in one. It adds a lot to their plate. And I think that's where that disconnect sometimes happens, is people don't realize how much one person is carrying as far as responsibility goes in the back of an ambulance. So,
do nurses have to do a paramedic ride-along or EMS ride-along or anything like that?
That's interesting, because that was one of the things I wanted to bring up today, I think, was that paramedics get a great perspective of the emergency room because of all the hours they're required to spend in one before they go out and start their career. And nurses really don't have that. They don't get that opportunity. And I call it an opportunity. It's not that they don't have to do it, it's that they don't get to do it, in my opinion. It's not offered in very many nursing programs, or any that I know of locally. I don't recall any of the people that I've worked with telling me that they had the opportunity for that. I've had some of the techs that I work with that are in nursing school that have taken that opportunity, found people that they know from our local EMS systems and asked, hey, can I ride along? Can I see what it's like out there? And, most people are open and able to make that happen. And I think that is a huge disservice to nurses in general, and the paramedics too, and the EMS side of things. It's for everybody that the nurses don't get that perspective. I think it would be extremely valuable that if they at least don't get that perspective of being able to go and ride out, that we create some sort of way to have like a liaison between the two professions to say, hey, this is what EMS is doing for training right now. This is kind of what their protocols are. This is what they're doing. And maybe, something, hey, this is what we're doing at the hospital. These are kind of what our protocols look like, what we're changing and doing that's new, and having some sort of information going back and forth that everybody can be more informed of what everybody's doing. Because I think that would help, is information is power when it comes to that sort of situation. So,
because nurses they can work on the ambulance, they can
Yeah.
work on flight, and that's
Right.
surprising that more programs aren't going towards like, hey, you got to do at least 12 hours or something like that on an ambulance.
Yeah.
Just
Yeah, I
one
think that would be
shift
great.
would provide some perspective that I think would be powerful, potentially.
Absolutely. Well, we have access to a paramedic program at Ivy Tech and a nursing program at Ivy Tech. So maybe we can, it could be something that becomes, it would be, I think, renowned. It would be one of the first nursing programs to do something of that, as far as I'm aware of, at least. I mean, now I'm kind of pigeonholed into Indiana, and Fort Wayne is, I'm familiar with just programs around here, but I don't know that I've ever heard of a nursing program that puts a huge focus on pre-hospital care or giving the nurses that perspective. So it could be something that we pioneer around here that would make a big difference.
I mean, you have to do a lot of clinical hours, correct?
For nursing,
Yeah.
it is quite a bit. It's not the same as a paramedic. I think I did more for my paramedic, honestly. Now, I will say I have an associate's in nursing versus a bachelor's, so there's more clinical time
Is
for
there?
a bachelor's degree. It's not a lot more focus. They have like a larger focus on, their clinicals are broken up different. So they have a community clinical where they go out and do like, community outreach stuff that nurses would do, and they do clinicals in leadership. Mine were more condensed because of its being an associate's program. And so I didn't get quite as much clinical time as a bachelor's program, which I feel like for me was okay because I had paramedic experience. I do feel like it's probably not as good for the new person coming in and just going straight from high school to nursing school. An associate's program maybe doesn't offer them as much clinical time, which is maybe a disservice, but it's definitely still worth it 100% for that associate's degree to be able to get into the field quicker and to be able to, you can always get that bachelor's degree on the back end. So I still encourage people to, seek those associate's programs and take them, because it can get you into that RN spot and get you learning, and you're going to learn so much in the job that bachelor's degree will kind of be, it's going to be a thing of the future. They're going to be required, I'm sure, eventually again. Parkview kind of went away with requiring them, and I think that'll come back, and I think other hospitals will follow that as well. But for now, when they're not, get in there and do it, because
Yeah.
it's a great thing.
What would you say to, it doesn't have to be someone in EMS, but just anyone who's interested in getting into nursing? It could be an EMT or a paramedic wanting to maybe bridge, like, what's my next step? Or just anyone listening who is curious about nursing school. Like, what would you say to them?
Go for it. Honestly, it's nursing different from being a paramedic in the fact that there's just so much versatility in that degree. So once you have a nursing degree, you're not just, paramedic. You can work on an ambulance for 911. You can work on a transport ambulance. You can work for flight. There are lots of different options as a paramedic as well. But the nursing degree opens up just another whole way to practice. I mean, you can literally go from working in a doctor's office if you're looking for something that's, if you just can't really handle, like, you don't want to be in the emergency side of things
The high
anymore. Say
acuity
you've been a paramedic for a while and you're looking to slow down. I know there's people out there that they go back to nursing school and they get a job working in, it's still a technical thing, like say cath lab or something like that, where it's very technical, but you're not in that high acuity, high stress environment constantly. And I think that it's something that nursing gives you that way to escape burnout in a lot of ways, which is an interesting thing. And I think that if you're a paramedic that's looking for a change, I think the best way to get into it is if you can find a bridge program, that's great. There aren't many here in Fort Wayne. There's not a great option. Ivy Tech doesn't offer a direct bridge in Fort Wayne. It's I believe in Terre Haute, or at least it used to be. I could be, I'm 5 years away from when I did it, but
You did a bridge program?
I did not do the bridge, so I had to go through just a standard application process for the nursing program here in Fort Wayne. So I went and found out what prerequisites I needed that I didn't get for my paramedic, because I did my associates in paramedicine through Ivy Tech as well.
What gaps were there? I'm curious, for someone who got their associates in paramedic
Very,
science.
very minimal.
I was gonna say, I started to go down that route, and I just had one class I had to take.
I had 2 classes. So it kind of depends on when you went to get your paramedic, there were a lot of class options, and you could have, some people, their prerequisites they take for their paramedic end up being all they need for nursing school. You might already have them all. For me, I think I added on, I had to take microbiology and I had to take like one math class, and that was it. Like it wasn't anything crazy. So I knocked those out in a semester or two, and then I was in the nursing program like the following semester. So it was pretty quick.
That's awesome.
And then now Ivy Tech's offers, or they offered it at the time as well, but they offer a summer semester. And if your grades and everything, they offer it to people at the higher end of the GPA for the program. And so that is great because I got through the whole program in less than 2 years, the nursing program. So it's very doable.
And I feel like microbiology needs to be in the paramedic program because have taken it and it made stuff make sense. Or,
Yeah.
you know what, after you get some experience and then go take it, it really helps.
I think that is the paramedic program does require, the prerequisites they require are the right ones. But I think that if you're heading in that direction, add on a couple more classes and give yourself that little bit of extra base of the sciences is a huge help in the long run. So I agree with that 100%.
Question I want to know. How much time do we have on a radio report, actually?
It's going to vary
Real talk.
It's going to
Give
vary
it
on
to us
who's
straight,
listening.
Grant.
It's going to vary on who's listening for sure. Typically, short, concise is the best. Why did they call you? What did you see when you got there? What did you do for what you saw? And a set of vitals. If you can keep it at that, you'll have the people's attention the whole time. They'll hear everything you said, and that'll be great. If you get off into they have a history of X, Y, and Z, or they've been sick for 3 weeks, here's what they felt for those 3. There's just sometimes people go off in those reports, and you can get off on a tangent. I was long-winded on my reports a lot of the times. The best phrase that you can use is you do the things I said, and then you add, we'll give you the rest inside if you don't have any other questions. And then if you have a Bible of information to give them when you get there, read it all out. Let them know. Here's everything else I have. We love information. We want to know everything because a lot of times these patients come in, we don't know it. I mean, some of them aren't in our system. We don't have any history. Their family doesn't come with them. We don't know what their baseline is. We don't know anything. So EMS has a great advantage of sometimes the family's on scene, but they just don't follow into the hospital. So you have that resource. And if you can gather as much information from those people before you come in, we love all of that information. We want all of that information, but just hold on to it till you get to the hospital and then give it to us.
Just not on the radio.
Yeah, the radio is basically, we need to know where we're going to put that person when they get to the hospital.
Yeah,
so we're triaging from that radio report. So it's just like our triage desk. When someone comes in, we ask them, a finite amount of assessment questions of, basically, when did this start? What's going on? And then we get a set of vitals, and then we kind of base off of their story, their presentation, and those vitals, we are able to decide, do you need to go into a higher acuity area, a lower acuity area? Well, we're doing the same thing off of that EMS report. So that's that. We need that information. And then those pertinent little nuggets of, this patient looks really dusky, this patient's really diaphoretic. Those things that you noticed that made you worried about the patient, tack those on in that part of what did you see? Because sometimes it's like, they called us for difficulty breathing, here's what we did. Well, that little nugget of, they call us for difficulty breathing, here's what we saw, and then here's what we did, can be really important in us deciding what we're going to do.
Yeah, me tagging on, they're getting really tired.
Yes,
that
absolutely.
tells you, like, okay, this is a step or two higher than maybe I thought.
Yeah, so now you say they're having difficulty breathing, they're getting really tired. Okay, well, now we know we're going to call the respiratory therapist. We're maybe going to get BiPAP set up in the room. If we are concerned based off their history, you might tell us they've had to be intubated before. Perfect. We might have intubation equipment ready when they get there. We're going to plan accordingly based on what you tell us. So those details like that are extremely important, but keeping it down to those finite details is what's going to keep. It's, anybody has a short attention span nowadays. What are we used to? 30-second TikToks, so we need it to, if it's in that 30 seconds, we're going to get all that information. You start meandering off past that 30 seconds and we're going to start to lose you a little bit. Is that right? I don't know, but is it just the reality? Probably.
Just listening to what you said about all the things that you're doing at that same time, like you're not just sitting there waiting for a radio report. It is one of your duties, but you're also taking care of multiple patients. You're also filling in gaps that your team needs.
Yeah.
So say, someone has a high acuity patient and they need more hands, like that's on you to help them do that.
Mhm.
And so you're spinning a lot of plates. It's not that you
Absolutely.
don't want to be thorough and listen to this radio report. It's more just, I only have a limited amount of me.
Yeah, absolutely. And, we have the doctors nearby the radio. And if it's something, if you guys, sometimes EMS comes up and will say, like, we have a trauma activate, we have a medical activate, because they recognize that this patient looks sick. And by putting those words at the front of your report, it does get us, get us engaged. So it's, your criteria to activate, not the same as our criteria necessarily. They do align pretty closely, but they're not always the same. But putting those words there at least gets us listening. And I feel like that is a disconnect in EMS is sometimes someone will say, I have a trauma activate, and they'll give us everything, and it doesn't meet our criteria. But their patient definitely had a significant trauma or, a trauma that was worthy of making note of, but it doesn't meet our criteria as far as their condition or vitals, and we won't activate it. So I've seen EMS providers very frustrated that they come in with a patient and we didn't activate it, and it just didn't meet our criteria necessarily. And we know patients sometimes that we can treat whatever that thing is without having to get a whole activate team assembled for it. And so that is, but so I want people to know that we didn't not listen to you. We heard the words trauma activate. We respect the fact that from your perspective, this patient is sick, and we're not discounting that at all. It's just maybe we go off of our protocols of who do we call, and it's when we activate all those resources, we're also charging the patient for all of those resources. So whenever a medical activate gets called, that's an extra charge on the patient. A trauma activate, that's an extra charge on the patient. So sometimes being a little bit more careful of, just throwing those out there and doing that, we can still provide the same level of care, but save the patient a little bit on that, and also just save the resources just in case that next patient is the one that actually does meet our criteria or need the surgeon and everybody else to be in the room when they
Yeah.
get there. So
Do you think a better word would be to use, be like, I have a significant trauma versus a trauma activate, or
I don't know that we necessarily have to go away from saying activate. I think that word is synonymous to all of us. We all know what that word means. We all know what people are thinking when they say that word. So I think it's the right word to use. I think it's just having the mentality that just because I say these words doesn't mean I'm going to go to one of the trauma rooms, doesn't mean I'm going to have the whole team when I get there, but know that we heard you and that we do have it in our minds that, we're telling the doctor about that patient. If we decide not to activate, the doctor's still well aware that that patient's coming, and likely one of the leads will be in the room to see that patient and assess them right away to know, okay, do we need to actually activate this or not, just based off of seeing the patient. We can't see what you guys are seeing necessarily. You guys, again, we have 30-second radio report to paint me a picture of what you see. We're not necessarily going to be able to always say, well, for sure off of that, this patient needs an activate. So we'll sometimes say, well, let's look at them when they roll through the door. If they roll through the door and they look bad, let's call it. Let's see them when they get in the room, and then we'll kind of decide based off of that. So
we've even seen you guys meet us in the ambulance bay. Like,
yeah,
is this what I think it is? And
right.
I'm trying to think about what you're saying too. Like, what you're saying is very helpful. I'm thinking when I would say the words activate,
Mm-hmm.
I would expect, like, okay, well, they're going to activate this patient.
Right.
But the disconnect here, I think, is you saying, like what you said, where maybe we could mitigate this problem without activating them.
Right.
Maybe we don't have to call A, B, C, and D to do that.
Right.
But we can still treat it as a serious and significant patient.
Absolutely.
But we don't have to, sound the horn necessarily.
Right. I mean, if you think about what an activate is to all of us, is it's a situation that requires resources. So in EMS, we're considering this an activate because it's requiring every bit of the resources we have to take care of this patient. So to EMS, an activate's a little bit different because when the resources that we have available, I can have 2 nurses and a pharmacist and a doctor and a respiratory therapist in a room, and I don't have to call an activate to get any of those. I can just call those people individually and get them all in the room if I feel like I need them. Or if I don't need all of those, but I need one of those things, then I can do it. So if it's, you call me and say you have a respiratory patient that's on CPAP already, and we're concerned that they need to either be continued on BiPAP or intubated, we can continue them on BiPAP and intubate them without having to make them a medical activate. because I can call the respiratory therapist directly and say, hey, can you meet me in this room in 5 minutes? EMS is on their way. We might need to intubate this patient.
It's not like all
and
or
they'll be
nothing.
there. Right. It's not all or nothing. So the things that a medical activate get me is I get my lab tech outside the room. I get my x-ray tech outside the room. And then I get my RT along with that. So when I do that, it sends a page to all of those people at once, and they all just come and converge at that room. I don't always need all of those resources. So if I can mitigate having to call all of them, sometimes we do, because it's just easier to get exactly what we need in the room and be more concise. Now, traumas are a little different. Different levels of trauma get us different resources. Sometimes, so if we call level 3 trauma, you'd say trauma activate, we call level 3 trauma, we're going to probably have you in a regular room. You're not going to go necessarily to one of the trauma rooms. I think that's a perspective issue as well. Doesn't mean that if you go to a room that's a regular room, it doesn't mean we didn't trauma activate the patient. It just means that they met our level 3 criteria, which means they don't necessarily, in our eyes, need one of the big trauma rooms, which we kind of try to reserve for those more significant traumas that meet that higher level of care. And so don't think we didn't. If you look and you see a lot of people, we activated it. We just put you in a different room. And there's even days where we just don't have a trauma room. So we'll be doing, higher level 2 traumas in a regular room. So I like just to kind of put that in perspective of don't think that we didn't listen to you just because we put you in, just some plain room. It's not a trauma room because sometimes we just don't have one.
Yeah, no.
It is actually very good because, I would take patients to like a regular room and be like, I am surprised they didn't activate that. Okay.
Yeah.
Maybe I said something wrong or, but yeah, no, that's a really good perspective.
It's not all about you.
You mean the world doesn't revolve around me?
No, that's a good, that goes to us EMS people.
Apparently not. He didn't even answer.
Yeah, he didn't even answer. He's like, no.
I said that because I know that I've felt that way. And like we talked about before, we think we work in a bubble in EMS and we just don't. We've said this multiple times on several podcasts. We don't. It's a continuum of care.
Yes.
And I don't know what resources you have. I don't know what's going on in your ED. So for me to have feelings about how you're handling my patient, that's just not something I should necessarily base my worth on or my value because I don't know.
Yeah, and I agree with that. I think that, our resources aren't always obvious. What we're doing in the background isn't always obvious. But if you call us a patient and you see the eye stats on the counter, they're little gray and blue boxes. You see those sitting there, know that we heard you, that patient was probably more sick. We're running the doctor or even the nurse thought ahead that we didn't activate it, but we thought ahead that this patient might be sick. We're going to get these labs right away. We're going to check on that and know just how sick they might be and whether we need to emergently jump on and start treating certain, lab values or whatever it may be. And so there's little things that we do that are probably not known or seen by the EMS side that are actually our ways of letting you know that we heard you and we are doing all the things that we can be doing for this patient. And I think that kind of all, like you said, continuum of care. Whenever I write an EMS chart, the very last piece of my EMS chart is a little tag thing that says continuity of care. And in that is transferred care to, Sally RN via verbal report in room, whatever, and it's continuity of care because the care didn't stop. That's where it's continuing. It's going on to them. So I like that you use that terminology.
I think Barry said it best in one of the podcasts. He was like, we're paid to do 3 simple things: airway, breathing, and circulation, and continue that and to keep that going. And then you guys are paid to fix whatever was causing those things to
the
not
disruption
work.
in those 3 things.
Yeah.
Our job is to find and fix whatever was disrupting whatever one or multiple of those 3 things that are being disrupted. So that's a great way of putting it. I've had EMS providers come to me, which it's nice to have been on the other side and have them come to me as a lead and after a call and say, would you have done anything different? Because I have enough paramedic experience that I'm trusted enough to come to, which is I feel great about that. And any of you that want to come to me and ask me questions, please do, because it gives me a big head and I love it. Most of them, I'm able to honestly look at them and say, you did a great job. There's nothing I would have done different. And don't beat yourself up because we did this or that when you first got here. We had the resources for it. You might not have. We had the hands to be able to easily do this. There's a lot of things as far as Fort Wayne EMS doesn't have RSI. So there's a lot of patients that taking their airway might be the right call, but if you don't have the right medications to take their airway safely, then it's not the right call. So it's okay to support that airway via BLS means as long as it's supported and get them to the hospital.
I love that you said that.
Yeah.
You mean we don't need to intubate everybody?
I don't think we do. I've actually even worked cardiac arrest in the hospital when they coded at the hospital that there are some of our doctors that will still place an iGel and work the cardiac arrest with an iGel because that is the faster access to an airway, and trying to intubate during CPR is not always the right answer.
Not very easy.
It's definitely a more difficult skill. Now, a lot of us have been able to do it over the years. I know I did it. I could do it without pausing CPR in most situations,
not
but
ideal.
but it's not ideal. And in a lot of ways, it could lead to, that iGel once it's in, it's non-visualized, but you can tell whether it's working. And we do all have an ego. So our ET tubes, sometimes we want to believe that, oh, it's working, it's good. We might not be getting the best readings or whatever it may be, but we're like, oh no, it's fine, everything's fine. That was a good tube. And everybody's. Nobody's going to let their ego completely overdrive it, but it might delay having that secured airway trying to get that tube in a more complicated situation than it has to be.
And these non-visualized airways are getting better and better and more
Absolutely.
ergonomic. And
Yeah.
we're using the AirQ3
Yeah.
at Fort Wayne. And
Mhm.
I've heard a lot of pretty positive things so far.
And we switched to that at East Central as well. And I am happy with it. I've seen a couple patients come in with them now, and they function well. Having the suction port is nice. I think that we're adding that ability. We are adding NG tubes onto the ambulances.
I heard that you guys
at
did
East
that
Central.
out there. That's
Yeah.
so
That's
cool.
cool.
So we'll be able to actually use that suction port to the best of our ability to actually decompress stomachs, which is a huge problem with any non-visualized airway. So it'll be very interesting to pilot that and see how it goes. Right now, we're only going to be doing it pretty much in ROSC situations, but with the ability to do it in others, if we talk to medical control or if we feel like it's needed, we could always reach out. But right now, it'll be in ROSC patients. We'll see how it is, and if it's successful, and if it is, then maybe we can move on to doing it in more situations. But it'll be very
Yes.
interesting.
For those listening, Caitlin, Grant, and I are not saying do not intubate. That's not what we're
Yeah,
saying.
No.
There are absolutely circumstances where that is warranted and needed, but I think Grant used the word ego, and that was spot on.
Yeah.
We need to nix that ego when it comes to dropping that ET tube, because sometimes it's not warranted, and if it's not there, it's not there, and you need to move on quickly.
Mhm. Absolutely. One attempt is fine. I know that protocols are probably still 2 attempts, I assume, for you guys too. I would say that in a lot of scenarios, you can tell in that first attempt if this is going to happen or not. If there's a clear-cut reason why it didn't happen on the first attempt, then I think the second attempt could be warranted. If you go in there and you didn't have suction prepared and you can see that suctioning would have gotten the airway, then pre-oxygenate again and get your suction prepared and get back in there, but and get that definitive airway. But if it's something that you go in there and the anatomy looks weird or something's off, there's airway swelling, trauma, things like that you just are like, I can't see anything. I don't know that I will be able to see anything. Grab that BLS airway and get it in there, because if you put it in and it fails, then, sure, you're going to have to go back to the other. But the success rate of those airways is pretty high. I mean, your failure rates are extremely low. It's likely it will be your answer, and it's likely it will be better for the patient. So,
And you can get it in like 10 seconds.
yeah, quick, super quick.
We do want to ask you if you have any recommendations when it comes to books, podcasts, any sort of educational material, YouTube channels, anything where you're like, I find this helpful and I would like other people to maybe check it out. Anything like that you want to plug?
I don't know that there's anything that I kind of just dabble in so many different ones. It's just stuff that pops up to me on YouTube, suggested stuff or whatever. So I don't know that I have one thing in particular that I would point out. I would say there's the IV guy, though, on Instagram, I think it is. I will say that his stuff is pretty good. He does lean more in the hospital side of things, but just his perspective of showing how IVs and like why they fail, why we have trouble advancing the catheters, why certain things happen. He shows it under ultrasound. He shows it so you can see exactly why some of your IV problems happen. And I think it gives a better perspective. I started doing ultrasound IVs in the ER. It's one of the things that I'm trained to do now. And so that's why I started watching him, but it gave me a better perspective of when I do a blind stick, why things are failing, why it's not working, and why I know to abandon that IV now and just go to a different one versus try to make this thing work. Like it's not gonna. You can tell based on what he shows you. Just there's a reason. The reason this isn't working is not something I can fix, and this IV is really just not ever going to recover. So there's just little things like that he kind of gives you an idea of. But otherwise, listen to all of them. I mean, that's my advice. Listen to everything whenever you can, whenever you have a minute and you're looking for something, or especially when you're new in the game and you're trying to just absorb knowledge, just absorb it from wherever you can, because there's so many good people out there saying so many good things, and there's never a time you want to stop listening, because I learn a new thing every single day when I'm at work, and I learn a new thing on the internet. I mean, even just a TikTok here or there will throw you something that's worthy of listening to. So it's
education is kind of moving its way into social media and things that we, I guess, consume on a regular basis.
Yeah, absolutely. Yeah, it's basically micro learning anymore is the way that everybody's learning. That's the new thing is, and there's apps now. That's what they're for, micro learning. They say ditch TikTok, go to this, which I don't know, maybe we need to create an EMS micro learning app. It would probably be a great thing. Just little snippets you can sit and flick through would probably be the new way to teach the young generation. But I hate to say I'm not the young generation anymore, but I think I've moved out of that role.
I think we I don't know. You and I are probably similar age. It's like,
so.
Caitlin, you're still.
I'm 27.
Yeah, you're still.
Yeah, we'll let her go. She's sub 30, so.
Well, Grant, I appreciate your time. Thank you for coming in. I think that this conversation has been really helpful for me, and hopefully others listening too. I think that you did a good job explaining your perspective as a nurse, and a nurse who has experience like understanding the EMS side of things. So I think people are going to be really apt to listen to what you have to say because you understand them.
Yeah, I really appreciate you guys having me on. It's something I've been talking about for a while, that we need to have more talks across the table for these. It's kind of or across the aisle, as they would say in the political field. There's just not enough going back and forth education wise or information wise. And I think it's great to be able to try to tie these two together. So I appreciate you having me on.
Absolutely.
And for everyone out there, just remember, we want to be better together and leave it better than you found it.